Within a 100-kilometer radius of where we sit today, there are more than 24 unreached people groups, and the population that's in the vicinity of 10 million people that Memorial Christian Hospital is actively striving to serve, both medically and to serve with the gospel. Memorial Christian Hospital opened in 1966. 54 years later, the new Memorial Christian Hospital is having a dedication, and we're celebrating the opening of the Furman Surgery and Critical Care Center. It is a dramatic, marvelous expansion of all that God led us to do here in the first place 54 years ago.
As I walked down the sidewalk into the building, one word kept coming to mind, and that was unbelievable.
Memorial Christian Hospital, you are well placed here to provide medicine, to use the skills that God has equipped you with to be able to help those that are hurting.
The capabilities of the Furman Center for Surgery and Critical Care are so crucial to who we are and to what we do. It's really the heartbeat of what we do, which is surgical care, critical care, complex care. Tirto Tripura is a 6-year-old little boy, and he got clipped by a vehicle, has an open fracture of his right tib and his fib. This surgery is an absolute game changer, and he'll be back on his feet this afternoon with crutches. He'll be getting his rods out within 3 months.
I watched the caring doctors and the nurses giving modern medicine, modern care and techniques to this hurting child. As a father, that crushes me. I want my own child to get the very best care, and that's what they get here at this hospital.
The new facility is triple the size of the old facility. We're now at 130,000 square feet. The capacity to expand our services and reach more people with the healing that modern medicine can bring in conjunction with the healing that the gospel brings to broken lives is exhilarating.
Yesterday, when I went on the ward rounds with Dr. Stephen Kelly and the medical team, I just saw miracle after miracle. So many people that are impoverished and without health care, and here they come to a Christian facility that provides excellence of medicine and the love of Christ. It's just miraculous.
This hospital is a magnet. It brings all of these patients in here, and then the platform for us telling them about Jesus.
Samaritans Purse supports this hospital because they're centered right in the heart of Hindu and Muslims. We have the opportunity to share the truth, the love of Jesus Christ with those that are hurting and that are in need.
We need to pray for fertile soil, that people's hearts would be ripe to hear gospel truth. My hope for the future is that all of those 24 unreached people groups become reached within my lifetime. Humanly speaking, that's laughable, but the Lord is able to turn that around on a dime to bring people to the light of the gospel.
My name is Dr. Lance Flyler. I'm the director of World Medical Mission at Samaritans Purse. We are in the country of Zambia at Chitokoloki Mission Hospital. World Medical Mission has sent volunteer doctors here to this hospital for many years to help these people. When I come here, it can't help but grab your heart because you see these people with disease and it's so advanced.
Some of these mothers and fathers come so far just to get to these hospitals here, and it's so important that World Medical Mission is helping provide medical equipment and doctors so we can help keep these hospitals going and provide the health care for these families in the name of Jesus.
You can just see behind me, I mean, this hospital is filled. And I can honestly say at being at so many of these mission hospitals, there's not nearly enough doctors and way too many patients. So just this morning, we went on rounds with one of our volunteer doctors, and he saw over 110 patients. Hospitals like Chitokoloki could not survive were it not for volunteers that come out and serve.
I'm Dick Furman with World Medical Mission. We started this post-residency program where we were asking doctors who felt called to full-time mission work to apply. It's evident these hospitals would be closed 10 years from now, 15 years from now, if it weren't for these young doctors that are giving their lives to the Lord in full-time service. Many of the hospitals that we are supplying with post-residents now are blossoming back to like they used to be 20 years ago, with the spiritual impact, with the medical impact. And that's going to allow these hospitals to continue on for years to come.
Boy, girl, girl. Name? No name yet? No name. This morning, when I got to go around the maternity ward with you, was so special. And I know for many moms back at home that to hear that heartbeat is a special connection for the first time. But the thought that many mothers don't hear the heartbeat until that baby comes out. And when you brought this tool out, I thought you were teasing me. I don't hear anything.
Let me see.
This is
Thank you very
for
much.
a hospital.
Thank you very much.
And to be a part of Samaritans Purse and World Medical Mission, to be able to partner with hospitals and staff that work so hard, and to be able to help provide medical equipment, it's just pretty special to be a part of.
Thank you very much.
That's your baby's heartbeat. You can hear it.
One of the hospitals we just came from, they have not had a functioning x-ray machine for several weeks now. That's devastating to the hospital. So many of these patients are in dire need of x-ray imaging to help diagnose and treat their ailments. And so it's essential that World Med continue to provide these medical supplies like the x-ray machines so that these hospitals can continue to serve the people of Zambia.
It is so important that we keep these hospitals alive, because it provides so much for a family, especially for women and children in these communities.
Samaritans Purse goes out to the ends of the earth to meet the needs of people that are poor and have advanced disease that would not have help otherwise, and we're meeting those needs.
When I was in fourth year in medical school, I went to India on an elective. The only group of patients we saw who were dying in numbers that shouldn't really were the maternity patients. The Lord burdened me with that and gave me a desire to be involved in addressing some of those injustices. We read Matthew 25 and Jesus talking about whatever you did for the least of these, my brothers and sisters, you're doing for me. Hi, Mama. Leah. So the least of these tends to often be in third world women who are sick. You're going to feel you had a spinal. Take another rung down the ladder would be the woman with pelvic floor disorders. They can't even tell their own husbands. It's the shame and the stigma associated with those things. That desire to be involved in overseas mission, we really felt like this was a good fit, and the Lord guided us here. The Samaritans Purse post-residency program is perfect for a Christian doctor who has thought about missions, even long-term missions. The Samaritans Purse is a bridge for that, because they help you with a lot of the logistics and spiritual preparation. And really, this is kind of a unique opportunity which you really shouldn't miss. And the reason I love what I do is because I see patients who are really miserable with pelvic floor disorders, really, truly the least of these. We do surgery, they go home, they come back after a couple of weeks, and they're absolutely overjoyed. They give me eggs. I've even got a chicken one time.
The way we express the love of Jesus Christ and the passion that he had is that we go out there and we serve others.
We go to the out-of-bound places, the ends of the earth.
The world is changing, but the gospel doesn't change. The message of the cross doesn't change. We're going to make every effort to share the gospel.
The world has been decimated by COVID-19, but the work here at Samaritan's Purse, it never stops. No greater need and no greater time than right now for us to go out and serve boldly in the name of Jesus Christ. During this pandemic, during all the fear that COVID-19 has brought to the world, this is when we go out and share the truth.
This is an opportunity to take the gospel to the ends of the earth. God has told us to go into the world, to make disciples of all the nations. That great commission is still in play today. We have a job to do. And missionary medicine is one of the great tools for evangelism.
Is there a sense of urgency? Yes, there is. Get out there to be a part of this. Right now, it's the time. In Jesus' name, amen.
So come, be a part of this. We need you.
Hello, everybody. Welcome to Samaritans Purse International Health Forum. Delighted to be with you today. We've got a great presentation, a topic that I'm extremely excited about, rheumatic heart disease in low and middle income countries. And we'll have three speakers today that are leading the charge. Really, they're pioneers in the management of rheumatic heart disease and cardiothoracic surgery. And it's just incredible the work that they're doing. Today, we're going to have the same format. If you would, just look to the right on your screen is the chat box. Encourage you to sign in your name, where you're watching from, and also we'll utilize that same chat box at the end for our Q&A session. So as always, we just want to start off with a word of prayer. Dear Heavenly Father, we just thank you for this day. Thank you for this technology and this opportunity here at Samaritan's Purse, Lord, to present this topic that is so critical in the developing world. God, just be with our three speakers today. Thank you for just their pioneering work. And I just pray that you speak through them to minister to us, Lord, that we may be compelled to join them to serve. And we thank you in Jesus' name. Amen. So I'm sure many of you all watching with me today are very aware. It's really an epidemic in many places around the world, certainly in sub-Saharan Africa. I'm talking, of course, about rheumatic heart disease. I remember the first time I went to Tenwick Hospital in 2002, and I was just devastated to see so many young children plagued by this disease. As you well know, it starts off like strep throat, and it's not treated. If it's not treated by antibiotics, it can lead to sequelae. That is infection within the heart valves themselves, and it scars them down, and it leaves these children impaired for life. They eventually develop all sorts of complications, congestive heart failure, arrhythmias such as atrial fibrillation, and ultimately it leads to an early demise. And I remember just serving in the wards there at Tenwick, and all we could really offer them was palliation. We could use medicines to help alleviate their symptoms and prolong their life perhaps for a time. But the ultimate management, the true treatment is of course, surgical intervention through mechanical heart valves. And years ago, we thought that was an impossibility. In fact, Franklin Graham posed the question, why don't we do that, to Dr. Russ White many years ago, and he said, we'll never do that at Tenwick Hospital. That's an impossibility. But God is a faithful God. He's a miraculous God. And today, Dr. White and his team, who we'll meet in just a minute, are actually doing just that. They are providing cardiothoracic intervention, putting in mechanical heart valves into these children and offering them physical hope and spiritual hope. So I'm just very excited. As you know, we're partnering with Tenwick Hospital to build a multi-million-dollar cardiothoracic center. And it's really exciting and just cutting edge work. So before we get started with our speakers, I'd like to just show a video just displaying this new cardiothoracic center. So please join me and watch.
Hi, I'm Jeremy Barr. I'm the project engineer for Samaritan's Purse here at Tenwick Mission Hospital. I'm excited to welcome you to the construction site for the new cardiothoracic center. Samaritan's Purse and World Medical Mission have been a partner with Tenwick Mission Hospital for over 40 years, and we're excited to step into the next phase of growth for Tenwick Hospital. We built 20 new apartments that will house the doctors that will be working at this new center. We are also working on the infrastructure development project with new water treatment plant, new wastewater treatment plant. And then finally, the center of the whole project is the cardiothoracic center.
Currently, right now, there's about 650 heart patients waiting for surgery. From a cardiothoracic point of view, I have one operating room 4 days a week. In the new facility, which will have 6 operating rooms, we will massively increase our capability. And I think we can finally make a real dent in that waiting list and take care of the thousands of patients who are out there in need.
In this region of East Africa, in Kenya, there's a disease called rheumatic heart disease, which is devastating and endemic. And so you have these kids, many, many thousands of kids, where their heart valves are scarred down and they go into congestive heart failure. And really the only effective way to treat these patients and truly save their lives is to replace their heart valves. That's what Tenwick Hospital is doing.
On behalf of Samaritans Purse, we want to thank you very much for your support over the years. And we want to ask you to continue to support us as we go through this project and as we bring it to fruition. Thank you very much.
All right. So as I said, incredible what is going on there at Tenwick Hospital. I was just actually over there, and they've constructed the apartments for the fellows that will be serving at this cardiothoracic center, but they're actually commencing work construction this very week of the new cardiothoracic center. And it's projected to open in January of 2024. So with that, I just want to go ahead and introduce our speakers that are doing this pioneering work. Folks, these 3 doctors are really, again, I can't think of a better word but pioneers. They're leading the charge in this, the work that will be going on. And let me just say too, they need our help. They need cardiologists, interventional cardiologists, clinical cardiologists, cardiothoracic surgeons, anesthetists, surgical nurses. They need a whole array of help. They can't do it by themselves. But let me start off. Dr. Russ White. Dr. White is a cardiothoracic surgeon. He grew up in the Belgian Congo. We know today is Democratic Republic of Congo. And he has been at Tenwick for many, many years. In fact, he's served as the chief of surgery there since, I can't remember the exact year, 1997. And has been serving there as the chief since that time. He first led the general surgery residency program, and his first 2 graduates of that program are his colleagues, Dr. Agneta Odera and Dr. Orega Leda, who I'll talk about in just a minute. In 2018, Dr. White became the director of this new cardiothoracic fellowship program. And actually, Dr. Odera and Dr. Leda are going to be the first 2 graduates. In fact, Dr. Leda has graduated from the program, and Dr. Odera will be graduating from the program this December. And so Dr. White is leading this fellowship program. And what's so exciting, so transformative is that Dr. White is training these doctors. Dr. Leda is from Ethiopia. Dr. Odera, it's her home country of Kenya. And really, they're the next generation of cardiothoracic surgeons that will be staffing this amazing facility that will be providing life-saving surgery for these children, thousands of children that desperately need it. So Dr. White, he's also a clinical professor with Brown University, and he just brings a lot of legitimacy to this program, and has done just amazing cutting edge work in cardiothoracic surgery, both with mechanical heart valve replacement as well as management of esophageal cancers. His colleagues, Dr. Leda, as I said, who is from Ethiopia, he and Dr. Odera, they were the first 2 graduates of the general surgery residency program, and are also the 2 first graduates of the cardiothoracic program. What's exciting, Dr. Leda, he just, as I said, he just received his board certification in cardiothoracic surgery, and he is the first board certified sub-Saharan doctor in cardiothoracic surgery. His certification is through an organization called COSECA, which is the College of Surgeons of East, Central, and South Africa. And Dr. Odera will be sitting for the boards this December, so you can pray for her too, but they're going to be leading the charge. These surgeons are incredibly qualified to lead the charge forward.
And it is just an incredible delight for me to introduce them to you as they talk about rheumatic heart disease in low and middle income countries. So without further ado, I'll turn it over to our three friends and doctors.
Thanks to World Medical Mission and Lance for having us present with you about rheumatic heart disease. I'm going to go ahead and share my screen with you all right now and give you a bit of an overview on rheumatic heart disease. So it's a pleasure to be with you. The people who will be presenting for you today, after noting that we have no disclosures of any type, are myself. I'm Russ White, the Chief of Surgery here at Tenwick, and I'll be followed by Drs. Agneto Dera and Dr. Araga Fakadu Leta, who will be sharing with you in portions about this. The objectives are what you see on the screen, to look at the etiology, epidemiology, and diagnosis of rheumatic heart disease. I'll cover that, and then Dr. Odera will cover the medical management of rheumatic heart disease, and Dr. Araga will cover the surgical management of rheumatic heart disease. From the beginning, I want to make a very important distinction, and that is between acute rheumatic fever, which is an acute infectious inflammatory event, and rheumatic heart disease, which is a chronic progressive process. And as you'll see, they're related, but rheumatic heart disease presents with varying degrees of valvular stenosis, regurgitation, chamber dilation, and rhythm abnormalities. Please bear in mind that difference between acute rheumatic fever and rheumatic heart disease. So disease progression begins with a streptococcal infection. And in most cases, it has been thought this is due to pharyngitis. There are some reports of other types of strep infections, skin related, but in general, we're talking about strep throat. Followed in 2 to 3 weeks by acute rheumatic fever, which we're going to talk about briefly. And then rheumatic heart disease itself really won't present for quite a few years, and leading to the things you see on your screen. And then the complications of that, which include heart failure, arrhythmias, thromboembolic events, and death, as we'll discuss. Now, the actual numbers of this, if you look at untreated strep infection, only about 0.3 to 3% actually develop acute rheumatic fever. And of those, about a third will develop rheumatic heart disease. So you're looking at less than 1% of untreated strep infection, which goes on to rheumatic heart disease. Now, if we talk about acute rheumatic fever, how does one diagnose that and what does it involve? Classically involves the Jones criteria, which we're going to review here briefly. And those criteria have had multiple revisions over the years. So the major criteria are those listed. And here's a simple mnemonic to help one remember. As you see here, Jones piece, but you have to remember the O is not an O, it's a heart. So because if you don't replace that, if you keep an H, Johannes doesn't really mean anything, but Jones does. So Jones piece, and these are the major and minor criteria. And as listed for the first episode, you need 2 major or 1 major and 2 minor. And for recurrent rheumatic fever, 2 major and 1 minor. 2 major or 1 major and 2 minor, or 3 minor criteria. So one of the criteria is erythema marginatum, and many people would say, what exactly is that? And that's one of those skin lesions that dermatologists will look at and tell you that's erythema marginatum. Here's a few pictures on white colored skin. And if you actually look up erythema marginatum in the on Google, you'll find it hard to find on dark skin, but in our part of the world, that's what we see primarily. As listed, it's not specific for acute rheumatic fever, but it is certainly one of the diagnostic criteria. If you look in darker skin, sometimes it's harder to see, as shown on the picture on your left. And again, one has to look for it. It tends to be a non-pruritic lesion, and so patients may not even realize they have it at the time. And then Sydenham's chorea is another one. Now, I'm going to just exit out of here for just a moment and show you a video of Sydenham's chorea, which is a bit unusual. Many people have never seen this before. This is a video taken right here in our own examination room. So this choreiform type movement of the arm or legs or both is something that you rarely see anymore, but that is Sydenham's chorea or St. Vitus dance, as has been called before. So let's get back to our normal view here. And moving ahead, how does one diagnose rheumatic heart disease? Well, here's a few statements from well-respected texts. A recent history of strep infection is key to the diagnosis of rheumatic heart disease. I would personally disagree with this statement for the following reasons, as I'll share. And this one, how is rheumatic heart disease diagnosed? People with rheumatic heart disease will have or recently had a strep infection. Now, while that is true, they may not share that with you. And that is clearly shown in studies where adults will give you a history 70% of the time that they've had a recent infection. But kids really many times will not. So the point I'd like you to take away is that just because you can't prove a strep infection does not mean that that patient has not had acute rheumatic fever and now chronic rheumatic heart disease. So the diagnosis of rheumatic heart disease is a combination of history, physical exam, and appropriate investigations. The history can be the most confusing, where children won't come in and say, by the way, I've had acute rheumatic fever in the past. You may have to tease that out of them, and you may never get that exact history. Investigations are important, and in this day and age, it is dependent upon echocardiography to diagnose these. And Dr. Odera will share with you a little more about that, as will Dr. Araga. Now, why do some patients get acute rheumatic fever and then rheumatic heart disease and others don't? We don't know the exact answer to that. Nobody does. But we do know there are some differences in both the host and the bacteria that lead to a immune response, molecular mimicry, where the body sees the heart valves as foreign, and we don't know why it's the heart valves per se. It's a very busy slide that you can look over on your own if you want to come back to this on the World Medical Mission site. But it shows you that there are different factors among the bacteria. There are different factors among the host with genetic predispositions that either that favor progression. As shown here, it is a female-dominated disease, so that it's a 2-to-1 ratio of females to males, and we certainly see that in our work here. And some will then go on to develop this rheumatic heart disease, which is a vicious cycle of ongoing repeated infections causing chronic valvulitis and progression to chronic rheumatic heart disease that leads to unavoidable consequences. The natural progression is, as described, infection before 5 to 10 years, onset of disease between 10 and 25 of rheumatic heart disease, and 12.5% of these patients will die every year with an average death age of 26 years. And nearly all of these patients will die if left untreated. How common is this disease? Well, it's nearly non-existent in most high-income countries. So like in the United States, you'll virtually never see this condition except in referral centers. However, in the world, conservative estimates would put the number at 34 million. And again, I say conservative because this is through those who are known. And I would say the numbers are much higher than that, with the majority of cases existing in sub-Saharan Africa. And again, most patients are between 5 and 25 years. How common is rheumatic heart disease compared to other common diseases? Well, let's take some important diseases. In the United States, breast cancer, one would find about 266,000 new cases per year. If you look at all cancers in the world, there were 18 million new cases in 2018. If you look at all patients with HIV in the world, 37 million. And with rheumatic heart disease, conservative estimate essentially equal to the number of HIV patients in the world. How much press does rheumatic heart disease get? Far less than that of HIV disease. Finally, there are many ways to intervene and prevent. This slide describes the different ways. Primordial prevention, meaning improving social factors and socioeconomic factors. Primary prevention would be the goal, to stop strep infections when they happen. That's not an option in many cases of the world due to the infrastructure. Secondary prevention is something we can do something about significantly, identifying those with established rheumatic heart disease and treating them prophylactically with penicillin, because we know it is the repeated infections which cause ongoing damage to the heart. And so monthly injections of long-acting penicillin can be life-saving for these patients. We've already begun this at sites near Tenwick, and we know that the average incidence of silent rheumatic heart disease is around 5%. 1 out of every 20 children in the high schools and primary schools will have silent rheumatic heart disease and could be treated with secondary prevention. Now, let's move on with Dr. Odera to some discussions about rheumatic heart disease diagnosis and medical management.
Thank you. It's a pleasure to join you all today. And we're going to proceed with the discussion of diagnosis and management. Again, I'm going to emphasize that this discussion now, in this segment, we're going to focus on established rheumatic heart disease where there is evidence of valvular lesions. So with valves affected in chronic rheumatic heart disease, the left side of the heart is commonly affected than the right. The exact reason for this is not known. And the mitral valve is the single most commonly affected valve, about 50%, followed by a combination of mitral and aortic. And then aortic valve in isolation, about 15 to 20%. The tricuspid valve alone is rarely affected. It's usually a consequence of left-sided heart lesion presenting as secondary tricuspid regurgitation. And pulmonary valve is practically never affected. Typically, the damage on this valve is by fibrosis of the leaflets, which gives you stenotic lesions, with reduction in the aperture of the valve orifice. If you have fibrosis of the chorda tendineae, it can result in retracting of the leaflets with failure of coaptation during diastole and with regurgitation. And therefore, sometimes you may have patients presenting with mixed valve lesions. On physical exam, the cardiac manifestations, the patients will typically present with congestive heart failure. And these findings include tachypnea, orthopnea, jugular venous distension, rales or crackles on pulmonary exam, hepatomegaly, which tends to be tender, a gallop rhythm, ascites, edema, and swelling of the peripheral extremities. Occasionally, can also have pericarditis that presents by the presence of a pericardial friction rub on auscultation. In association with this, if there's significant effusion that attends it, they may have cardiac dullness to percussion, muffled heart tones, paradoxical pulse. And on echocardiography obtained emergently, you will see an indentation of the right ventricle due to failure of expansion on diastole. This is classically the D sign. And this here is an echocardiogram picture, a biventricular view or a subcostal view that shows you the large pericardial effusion as a black echogenic area. This here is a left ventricle, and this is supposed to be the right ventricle, but it significantly collapsed in diastole because of impaired filling. Other than the classical heart failure symptoms that we know are described by New York Heart Class 1 to 4 based on the severity, We think about symptoms like dyspnea, exertion, orthopnea, paroxysmal tunnel dyspnea, and pulmonary and peripheral edema as described above. It's important to entertain differential diagnosis that can be confused and result in missing the diagnosis of a heart lesion. One of the common ones is community-acquired pneumonia or asthma. We've heard of the term cardiac asthma. Patients, especially with left-sided lesions and predominantly mitral stenosis, can present with significant trills and early pulmonary edema. This can be confused for pneumonia or asthma, and especially if they have oxygen requirement. Similarly, patients with severe critical mitral stenosis can develop significant pulmonary hypertension, and this may present with massive hemoptysis. And in our setup, especially in sub-Saharan Africa and Asia, this can be confused for pulmonary tuberculosis. However, it's important that to note, we have seen patients who have coexistent pulmonary TB and rheumatic heart disease, and it obviously complicates their management. And then also ischemic heart disease is not common in our setup, but aortic stenotic lesions typically present with chest pain, angina, and syncope. And so that would be one differential. And patients who have significant chamber enlargement from long-standing rheumatic heart disease can develop loss of their atrial kick and present with an arrhythmia, the common one being atrial fibrillation. And over time, due to stasis in flow and chamber enlargement, they can develop thromboembolism. And this intracardiac thrombi can be embolized, and the patients may present with stroke, with paresis or mesenteric ischemia or limb ischemia or renal failure. And this mentioned presentations may be the initial diagnosis that the patient comes with, and then the heart problem becomes a secondary diagnosis. And occasionally also we have patients who come young in their pregnancy or much older who come in with complicated pregnancy and difficult labor and childbirth. And actually it's because of acute decompensation from a non-diagnosed cardiac lesion. So it's just important to remember these differentials as you see these patients. Also, in addition to this, they may come with cardiac hemolytic anemia, and especially with significant valve stenosis because of the deformed valve and turbulent flow across it. They get disruption of the red blood cells, and so they present with microcytic anemia, and occasionally they may have platelet destruction as well. Other than cardiac manifestations of rheumatic heart disease, patients may come with abdominal pain and vomiting. And usually this occurs at the onset of acute rheumatic fever, but can present with the chronic states with established valve disease due to a low flow state to the gut. So they may have vomiting and feeding intolerance and mesenteric ischemia. And this might even mimic acute appendicitis or a diarrheal illness. Epistaxis may be associated with protracted rheumatic carditis or due to the disrupted platelet function as they flow across the valve. Any patient with rheumatic heart disease that presents with fever, it's important to exclude native valve endocarditis or even prosthetic valve endocarditis if they had prior surgery. And sometimes this may be the initial presentation with septic emboli to the brain, where they present with brain abscesses, splenic abscesses, or renal abscesses. And as mentioned before, pneumonia is a great masquerader that has been many times confused for actual acute decompensated heart failure. So how do we make a diagnosis of rheumatic heart disease? Other than the clinical presentation with the symptoms, the signs on physical exam, typically with long-standing disease, the patient is cachectic due to poor nutrition status and a high catabolic state. They may have abnormal pulses, like severe aortic regurgitation can have bounding pulses, or severe stenotic lesions, and may have very poor, almost non-appreciable pulses. On auscultation, on cardiac exam, they're typically classical murmurs. If you hear pansystolic murmur in the apical area, you tend to think of mitral regurgitation, and it's usually due to rupture of the cord of the papillary muscles or the valve disruption. Mitral stenotic lesions present with an apical diastolic murmur. This can actually be relative stenosis with severe mitral regurgitation because of the high-grade flow with a large regurgitant volume, or it could be established stenosis from thickened and calcified valve. And then if you hear murmurs over the upper left sternal border, typically diastolic murmurs would be aortic regurgitation presenting with bounding pulses, and there are other myriad signs and that can be elicited, like a pulsatile uvula, pulsatile capillary bed, a pistol short murmurs of the femorals. There are multiple aortic regurgitation signs. Typically, aortic stenosis lesions present with apical systolic murmurs that radiate to the carotids. So for the diagnosis of rheumatic heart disease, other than the clinical exam findings outlined above, imaging is important. So an electrocardiogram obtained may show you a first-degree heart block, atrial fibrillation features, and chamber enlargement features. And I'm not going to make you echocardiographers, but it's just important to be able to identify some views. So this is just an image of a patient. Just remember that the probe is on the skin. So any color map that goes towards the probe is red, and away from the probe, that is away from the skin surface, would be blue. So this is a mitral regurgitation lesion showing you in diastole, the mitral valve is supposed to co-opt and close, but it remains open and there is leaking of color into the left atrium. And similarly in this apical four-chamber view, with mitral stenosis, during systole with ejection, the valve is supposed to open, but as you can notice, there is thickening and bowing of the mitral valve here, and on cross-sectional view, you can see how thick the valve is, and there's narrowing of the aperture, and there's a restricted flow on the color map. This is a patient with aortic regurgitation. Similarly, in diastole, in systole, the aortic valve is supposed to close, but you can see there's wide open leakage there. Similarly on the cross-sectional view. And then with aortic stenosis, there is failure of flow as well. So for the medical management, in managing of an acute rheumatic fever episode, penicillin, whether oral or via intramuscular injection, has been shown to be superior. For 10 days, the single dose modality is better tolerated with better adherence. And for patients who have penicillin allergies, then azithromycin or clarithromycin would be recommended. For patients who have established recurrent episodes of rheumatic fever, secondary prophylaxis is recommended. And the American Heart Association gives recommendations based on whether there is evidence of associated carditis or valve disease. And they give stipulations for the duration for which the prophylaxis should be given. You can refer to this slide later for future reference. It's important to medically optimize the patients with rheumatic heart disease prior to recommending surgery. It's important to note that these lesions will either affect your preload, afterload, your rhythm, or contractility. In general, stenotic lesions cause more hemodynamic instability, and they may require urgent mechanical relief by either interventional means by balloon valvoplasty or by surgery. Regurgitant lesions tend to be tolerated better or longer with medical palliation. So to offset preload with massive edema states from right heart failure or left-sided failure with pulmonary edema, diuretics are recommended. To manage the rhythm, commonly atrial fibrillation, then digoxin, amiodarone, or beta blockers are used. Generally, for regurgitant lesions, it's important to allow some compensatory tachycardia to improve their cardiac output, while for stenotic lesions, bradycardia helps with this. To improve contractility, inotropes like digoxin and milrinone or dobutamine may be helpful, and vasopressors sometimes may be needed. And then afterload reduction can be achieved by ACE inhibitors and similar drugs, but these should generally be avoided in stenotic lesions as they worsen the symptoms. There is a role for sildenafil in helping with secondary pulmonary hypertension due to severe mitral stenosis as the patient is being prepared for surgery. And then the anticoagulants are important to use in patients with atrial fibrillation and chamber enlargement due to their risks of forming intracardiac thrombi. So in general, patients who come in acutely decompensated, it's important to determine whether this is the first or recurrent episode and what the offending reason is, whether they defaulted on their medications or if they have some infection or other systemic illness. Issues like sepsis or malnutrition and anemia should be addressed. And for female patients, it's important to address their obstetric career and challenges of managing cardiac disease in pregnancy. And generally, from my experience, we've noticed that patients who have several decompensated episodes with hepatopathy and jaundice and ascites tend to do poorly with surgery. So now I'm going to invite Dr. Arega Fekari to take over on the discussion of surgical management. Thank you.
Greetings to all, and thank you for having us. And it's a pleasure to share with you on the surgical management of rheumatic heart disease. As it's mentioned very well by the previous speakers, my colleagues, the patients with failure of prevention or early diagnosis and intervention leads to irreversible damage to the heart valves, which in turn result in severe morbidity and mortality. So I'll be talking some of the interventions that can be done after the medical optimization took place. So the surgical options for rheumatic heart disease patients include many of options listed. We'll be going through some of them. So in our setup, most patients with rheumatic heart disease present with later stage of the disease that results in decompensated heart failure due to stenotic lesion because of there is no forward flow and very, very compromised ventricular filling. And also this contributes up to 34% of the patients with a stenotic lesion. And then pure valve regurgitation accounts for about 20% of the patients. And most of them come with combined regurgitant and stenotic lesion, which accounts for over 40% of them. Because of the long-standing process of this disease, patients will have either thrombus formation in the left atrium usually, and pulmonary hypertension as a result of backflow of blood into the pulmonary veins as the stenotic lesion imposes great obstruction to forward flow. And also as a result of dilatation, as Dr. Odera mentioned before, atrial fibrillation is one of the commonest complications of this lesion. At this stage of the disease, patients would warrant surgical intervention for most of the cases after the medical optimization is done. So the as is well mentioned, mitral valve is the most commonly affected, and followed by aortic valve, and tricuspid is about 10%, and combined aortic and mitral is also accounting for significant portion of the lesion. Pulmonaries are less affected because of only reported cases so far. And the reason is not well established, but it's mainly suggested because of the shear and tear in the presence of inflammatory process going on that pressure generated in the left side has affects the mitral first most because of the large surface area, and the aortic to be followed with. So as you, just to show you, this is a healthy valve on this drawing, and in a normal state, it is all in, when it closes, it look like very competent. This is very important to allow forward flow and preload, as well as prevention of backflow when the subsequent chambers are closing and opening. And the AV valves, which is a tricuspid and mitral in opening state, look like this to allow blood flowing preload to the ventricles, and during which the semilunar valves are closed. And then when the ventricles are contracting to eject into the pulmonary and systemic circulation, the AV valves are closed to prevent regurgitant flow back into the atria. So this is what get disrupted when the infection or the inflammatory process that affects the valves takes place. And you can see here the mitral valve fully open, And in this abnormal or stenotic lesion, you can see it is severely compromised and not allowing ventricular filling, which will compromise also systemic outflow. And on the aortic, similarly, in the bicuspid or tricuspid leaflet, it narrows down. That will affect patient not to have adequate filling and outflow, which will affect the patient performance, and the patient will present with symptoms that gradually progress to the decompensated heart failure eventually. So this shows the transesophageal echo 3D view of mitral valve stenosis, which completely shows that it's so narrowed and a very tiny orifice, and the flow across this is not adequate to fill the ventricles as for adequate systemic outflow, which will affect patient performance and also cardiac function, gradually ending to severe decompensation and mortality if not intervened on timely fashion. So this also because of tight mitral stenosis, as you can see here, and it end up, the blood is very slow and swirling in the dilated left atrium, and also the thrombus forms in the appendage, and eventually this can either break up and shower the brain, causing stroke or any other vital organs. So this is basically the consequence of a stenotic lesion as well, which is a commonly affected valve, mitral valve zone. This is a tissue specimen for mitral stenosis and aortic stenosis, which is severely affected and narrowed down, very tiny orifice limiting the inflow and outflow. Inflow to the left ventricle, outflow from the left ventricle. This is very significant challenge in patient survival. So surgical, we want to see the following in order to go ahead to do surgical intervention. That is in stenotic mitral lesion and regurgitant mitral lesions. And these are the echocardiographic findings that need to, in addition to the presence of patient's physical finding or clinical presentation, these are the findings that will require surgical intervention when the mitral valve area is less than 1.5 and the gradient across the stenotic lesion is greater than 10 millimeter of mercury, ejection fraction drops below 50%, and also moderate lesion in the presence of the other valve significant lesion, and also the when the right ventricular systolic pressure is greater than 50, which is also one of the complications due to pulmonary hypertension as secondary to the left side lesion as well. And failed valvuloplasty, also an indication for surgery. In the regurgitant lesions, also the same. There are other parameters that need to be acquired by echocardiography that qualifies a patient for surgical need before it further deteriorates. And then for aortic valve as well, you can see these are the parameters that need to qualify in echocardiographic evaluation for a patient to, because valve surgery, open heart surgery is a huge undertaking. So we want to make sure that the patient qualifies or not delayed for the intervention as well. So there are different surgical treatment options available to take care of these diseases. And balloon valvuloplasty is one, which is mainly used in mitral valve intervention. Valvular repair and valvular replacement, which is bioprosthetic and prosthetic mechanical valve available. And there are pros and cons for each, and less durable for bioprosthetic, about 15 to 20 years. This is well suited for patients over 65 years of age. There is no need for anticoagulation for such patients unless the patient is in atrial fibrillation. And mechanical valves are very lifelong, durable, but require lifelong anticoagulation as well. These are some of the options of the bioprosthetic and mechanical valves that was used in different companies, as some of them are endovascularly replaced, like this, the TVARs and TVI. So percutaneous mitral balloon valvuloplasty is minimally invasive, and it's also excellent in pregnant women as a bridge for surgery, helps in medical optimization in patients in significantly decompensated heart failure state. Indications for this include low Wilkins score, and this one we will see it in later on. No presence of atrial thrombus or clot in the left atrium, and no moderate or severe mitral regurgitation, mitral valve area less than 1.5 centimeters square. And so this Wilkins score or Boston score is a 2D echocardiographic finding in a patient in rheumatic valve disease to decide whether patient would benefit from balloon procedure or need surgical valve replacement. This is a 1 to 4 score looking at leaflet mobility and leaflet thickening and leaflet calcification and subvalvular apparatus changes like thickening or shortening as well. So as you can see on this chart, is well detailed out when to score 1 for mobility and thickening and calcification, as well as subvalvular thickening. The score is out of 16, and if a score goes above 8, usually the balloon success is extremely low. And as well as for those who are score of less than 8, the success with the balloon intervention is great, and it gives quite a number of years before needing surgical intervention in the future. So major limitation for Wilkins score, that's why there are echo score and biomarker score. Some others are coming up to replace or combination of them to be used for accuracy. And these are the few limitations of this. So when it is done, basically it's transvenous and goes into intra-atrial septum puncture and ballooning the stenotic valve. So mitral valve repair or valve repair is one option, which by augmenting, putting tissue into for the retracted and thickened valve, or delamination, or certain procedures so in the commissurotomy and commissuroplasty to make the valve competent. And so the pros and cons for this is you preserve the geometry and the structure of the atrioventricular continuity, which will preserve the function and longevity of the heart, and no need for anticoagulation unless the patient is in atrial fibrillation. But the con for this one is less durable, high likelihood of disease progression requiring surgical intervention sooner than later. And so rheumatic tricuspid, as we said, is rare, about 10% comparing to 80 to 90% of aortic and mitral. And so the indication for surgery is the parameters of gradient across and the significant dilatation of the annulus, as well as the presence of severe regurgitation. I'll turn over to Dr. White for a summary, and thank you for your attention.
All right, well, let's summarize a little bit here. Diagnosis is really a key, and if you don't think of it, you won't diagnose it. So we see patients all the time here at Tenwek Hospital who've been treated for something other than heart disease, for pneumonia, or failure to thrive, or other conditions, which is really all rheumatic disease. So please think of it when you're out serving in high incidence areas, you've got to look for it and consider it, or you won't find it. Medical therapy should be initiated for all cases of rheumatic heart disease. So every patient needs monthly penicillin. You will save many, many lives by simply giving that monthly durabiotic. And many patients will need other medications when they become symptomatic from their disease. And finally, surgical therapy should be recommended before patients become end stage. Once again, here in Western Kenya at Tenwick Hospital, we see patients every single day who should have been referred for surgery far, far sooner. Now, I realize many places in the world, surgery is not even an option. And we're doing everything we can here to train people for the future so that it is more of an option in sub-Saharan Africa. As long as this continues to be a disease, and I think it'll continue for many decades in this part of the world, it's important for us to know a little bit about rheumatic heart disease. Once again, thank you to all of you at World Medical Mission, and we're going to end our recorded point here, and I think we'll be live with you on Wednesday evening, our time, the 14th, to take some questions. Thanks very much.
All right. Well, I just really want to express my gratitude to Dr. White, Dr. Agneta, and Dr. Arega for an incredible presentation. Again, I am amazed at just your fund of knowledge, your capabilities, and to be doing this cutting edge work in such a resource restricted environment is just amazing and really just speaks to the blessings of our Lord. And so thank you so much. And with that, I just want to pose to our audience, listening audience, this is just a time for questions and answers. So this is a great opportunity. If you would just utilize your chat box to pose any questions to these three doctors. Thus far, I'm just waiting on questions. In fact, actually, I have one as I speak. This is from Gina, and she says, what kind of follow-up do you offer in Tenwick? Are patients compliant with monthly IM injections, I guess, of penicillin? And she just says, great discussion.
Lance, I would ask Dr. Odera, who's on the call, to comment on that because she sees a lot of patients in our clinic. And so, Dr. Odera, can you give a reply to that, please?
Yes, Gina, thank you for your question. So we use a follow-up of patients to our clinic actually as a marker of their future adherence to care after surgery, because as we know, surgery is just not a one event thing for them, but it's a lifelong commitment to care for their cardiac disease. With improved roads in our counties, across our counties, and improved communication with mobile networks, we're actually seeing more patients who are adhering to their clinic follow-ups, and the patients who come for their penicillin shots for secondary prophylaxis is actually improving now compared to earlier years. We take a lot of initiative ourselves to make phone call follow-ups after establishing rapport with patients and their families, and trying to identify reasons why they may fail and address them. So I would say over the years, this has significantly improved. And again, as mentioned, we use it as a marker to see which are ideal candidates that may continue with their care after surgery. Thank you.
Thank you, Agneta. And I can just say, as part of the plans for the new cardiothoracic center, prevention is certainly going to be a strong component. They certainly are going to develop a public health intervention with the administration of penicillin through the school system. And so that's, prevention is certainly hallmark to part of this program. Next question from Dr. Alan Sawyer. In terms of the CME questions, is right heart failure a part of rheumatic heart disease?
I can answer that quickly. The answer is an overwhelming yes. It is. what may sound a little paradoxical is, as described by both other speakers, it's primarily the left-sided heart valves that are affected.
Mm-hmm.
However, due to that long-standing left-sided heart valve valvulopathy, you get right heart failure. And we see patients in the hospital right now admitted for their right heart failure with massive edema, ascites, hepatopathy, hepatic encephalopathy, all these things. So the answer is yes. And there's also some, there is some carditis that comes with rheumatic heart disease. And so most of the right heart failure is secondary to left heart disease, but there is some that is innate as well. Thanks.
Right. I think the most common cause of right heart failure is left heart failure. So yeah, very good. Thank you so much. Any other questions for us? While I'm waiting on questions, I just want to really just emphasize what stress what I said in the beginning is this is unparalleled. This new cardiothoracic center that will be opening in 2024. And so if you feel really a burden, a calling, I know Dr. White would appreciate many clinicians coming forward to participate in this incredible ministry. And really what's so incredible about it is we're really medically addressing the heart. But as you know, here at World Medical Mission and Samaritans Purse, that is just an opportunity, a door to open, if you will, to reach out to them spiritually, to address their heart spiritually. So really encourage folks. A question posed to Dr. Agnetta and Dr. Orega. If you were speaking, it says, please turn on your video so the audience can see you. It says, next question, how do you manage the logistical problem of anticoagulation at Tenwek? That's one that I've been very amazed about. So anticoagulation.
Ariga, why don't you take that on? I hope you've both done your hair. It looks like Agnetta has, and Ariga will look smart, I'm sure.
They look good.
So,
they look great.
Yeah. Ariga, if you can turn on your video and share with us about our anticoagulation problems that we face.
Okay. Yeah. So. It is a real challenge, anticoagulation, especially for patients who, as Dr. Odera mentioned before, the road infrastructure and awareness level of our patient is significantly improving, but that does not mean that we don't have problems with it. There's sometimes patients come with stroke because it is undercoagulated, and then sometimes the anticoagulation level is low. And the other thing is sometimes they come with bleeding because of either the diet or the brand of the anticoagulation they take, the warfarin. But we, throughout time, like since we started this, it has been improving significantly, but we still struggle sometimes with a patient who is coming from very far in Maraland and very peripheral areas where they don't have good access. But in most of our patients, nearby hospitals are able to do it now. So once we establish a treatment level of their anticoagulation, we send them and ask them to call us with the result in 2 weeks, in 3 weeks, and then keep doing that. And with that, we have achieved significantly that anticoagulation level with minimum expense. And most of our patients are also in insurance fund that can pay for clinic visit for that. So that is minimizing, but there are a lot of work to be done on that front still. Thank you.
Thank you so much.
Thank you. Maybe if I can just add a comment. Thank you, Dr. Rega. I think some of the challenges we see with anticoagulation therapy here is that there's several drugs out, generic drugs made by different companies with different excipients. And sometimes we're really not sure what the quantity of the active ingredients are. And so that has clearly posed a challenge. And then secondly, there's inconsistency with the laboratory reportings for the INR levels for monitoring, especially for Coumadin. And even at our own hospital, sometimes you can have one patient whose levels are very high in the morning and you repeat the test in the evening and they're significantly lower. So that clearly creates a challenge in getting a therapeutic level for the mechanical valves. And the challenge also is seen with patients who get pregnant. As mentioned, some of them are not aware that they have rheumatic heart disease and it's diagnosed late in pregnancy, or some are on warfarin and don't get checked appropriately. And so those, I think, are still teething problems that we have to muddle through with anticoagulation in Africa.
Yeah.
And I'll just jump in and say, we're working on publishing this data, but I can tell you the data is going to show that we have many more patients die of bleeding than we do of clotting. And warfarin is a dangerous drug. It's helpful in the right settings, but it's also a dangerous drug. So we're working on best suggestions for sub-Saharan Africa. What's the right answer? But it's something we struggle with every day. And I would say, Lance, I see Brett Stevens has offered to show this in our presentation. People didn't see this 6-second video of Sydenham's chorea, and many people have probably never seen that. And I think Brett's happy to play it. It's like I say, 6 seconds, and you'll see what Sydenham's chorea looks like.
Yeah, let's see if we can't conclude with that video. Is that available to us?
So there you go. There's the arm shaking repeatedly, this choreiform jerking, and that's taken right in our clinic. So you can, it's not common, but you can keep your eye out for that if you're in the right setting.
Wow. Well, let me conclude. Dr. White, Dr. Agneta, Dr. Orega, that was, again, an amazing presentation. You guys, the Lord is using you to do amazing work to save lives. Medically and spiritually. And I just pray as we go forward at Samaritan's Purse and World Medical Mission, we will join you in this calling. So in closing, I just want to remind our listening audience that CME credit is available with this presentation. You should in the very near future receive a recording and proper instructions to complete that CME. Just encourage you also, if you haven't, look at our archives. We have hundreds of presentations with CME attached at health.samaritanspurse.org. And there's no other site that has the same presentation with all this array of medical information from a Christian perspective. So I encourage you to go to that website. Want to remind everybody, prescription for renewal will be in Orlando, September 16th through 19th. So if you haven't signed up, please do. There are a lot of scholarship opportunities there. And I think you will not regret joining us there in Orlando. And just want to remind everybody in closing that our next webinar will be Wednesday, August the 11th with Dr. Robert Spencer. Many of you all know Dr. Spencer. He has served many times at World Medical Mission and with our DART program. So please do join us Wednesday, August the 11th at 12 noon Eastern Standard Time. With that, God bless you, and thank you for your participation.
Thank you so much.